Okay, so I have four fairly simple goals for today's presentation. First of all, I'm going to show you how to eliminate the federal deficit. I'm going to show you how to reduce employers' health care spending and premiums. I'm going to show you how to improve care for patients and get your employees back to work faster. And I'm going to show how to make physicians and hospitals more profitable. Now, you can tell me how well I did at the end of this, but you can imagine I'm going to have to cover a lot of stuff fairly quickly to cover all of that. And I will make all of these slides available to everybody, so I'll even show you where you can download them at the end. Now, this is the chart. Everybody shows these charts about the GDP. This is the chart that matters. The chart that matters is the fact that healthcare is the thing that is driving the federal deficit right now. All those folks in Washington debate about spending and everything. The issue is if they can't figure out how to fix Medicare spending, they're not going to be able to fix the deficit. But if you're sitting in Congress, you think you have two basic options: spending, quantity times price. So your two choices are you can either cut services to seniors or you can cut fees to providers. Guess which one they're going to pick? Now, let me ask you, which major industry in America tells its key professionals that they're going to cut their salary at the end of the year by 25% whether they're doing a good job or not? That's what Congress threatens doctors with every year. It's called the sustainable growth rate, and literally every year they're told at the end of the year, your pay is going to be cut by 25%. Now, of course, that's crazy to say that the key people in healthcare are going to have their salary cut by 25% whether they're doing a good job or not, so Congress never does it. But in fact, what has happened is they also haven't given them a pay increase for a decade. So their pay is actually 25% lower today than it was a decade ago because Congress hasn't figured out how to solve that particular problem. Now, what has happened historically is that whenever Congress and Medicare cut fees to providers, they have to raise their prices to all of you to be able to make up the difference. That's the famous cost shift. The GDP chart that I like is this GDP chart. That if you look at the blue bars are the public spending and the orange bars are the private spending in major developed countries around the world. And you notice that the blue bars are actually the same. Public spending is the same as a percentage of GDP in every major developed country. What is not the same is the private spending. Because healthcare spending in this country is actually making private businesses uncompetitive in world markets because so much is being shifted on the private sector. And businesses are then shifting costs increasingly to employees. So employer contributions doubled during the decade of the 2000s, and they increased employee contributions tripled as a result of all that. What we need is a way to reduce healthcare costs without taking away stuff that patients need and without cutting the fees to providers. But you can't do that from Washington. It has to be done at the local level because that's where healthcare is actually delivered. Now, can that be done? A lot of people think it can't. Some of the discussion earlier on this morning suggested that you've got to take a lot of stuff away from patients. I don't buy that. I think there's three ways that you can reduce costs without rationing. One is by keeping patients healthy. If they don't get sick, they don't have healthcare costs at all. If they do get a health problem, and particularly chronic disease, which is one of the major drivers of healthcare costs in the country, to help manage that condition in a way that doesn't have them ending up in the hospital as often and getting as many unnecessary procedures as they do today. And when they do genuinely need something, that they don't get complications, infections, readmissions, and that they get that care as efficiently and effectively as possible. Now, the nice thing about thinking about healthcare costs this way is all of these things would save money. But they're all also quality improvements. And if we told the American people and the citizens of Wisconsin that what we're trying to do is to help you stay well, to help you avoid having to go to the hospital if you don't need to, and to make sure that when you do go to the hospital, you have a good outcome, I think most people would say, well, if that's what healthcare reform is about, sounds pretty good to me. How big are the opportunities? Well, they're huge. National data say that between 5 and 17% of all hospital admissions are potentially preventable. The chronic disease admissions, the unnecessary surgeries. We have 3 adverse events happening every minute in this country. Wrong side surgeries, infections, complications that cost billions of dollars, as Reid said, have been happening since the Quality Chasm Report and since and before. And a lot of the major specialty societies are starting to admit that a lot of the things that we do to or for patients aren't necessary and in some cases may actually be harmful to them. So I think that rather than starting every conversation about healthcare spending with talking about the things that we want to take away from patients and how we're not going to give them that new technology or drug that could save their life, what we should be spending our time on is how to help the patient stay well, how to help them avoid going to the hospital if they don't need to, and make sure that they have better outcomes whenever they do go. What's the barrier? The barrier is the way we pay for healthcare today. Because if doctors and hospitals reduce infections, complications, and readmissions, they will lose money. If doctors and hospitals keep patients out of the hospital, they will lose money. And nobody in healthcare gets paid at all today when the patient stays well. That's not exactly a prescription for success going forward. So to understand how to fix that, I want to give you a very short course in the economics of healthcare. Part number one, where's the money going now? So these were numbers from a couple years ago. These were projected expenses. But left side is the commercial spending, close to $1 trillion nationally. Right side is the $500 billion in Medicare spending. And you can see where all the money is going, doctor services, hospital services, et cetera. But key thing about this chart, the physicians are only getting about 25% of the money. That's actually a little bit exaggerated because some of the things in there aren't really actually physicians. But they're getting about 25% of the money. Most of the money is going to something else, and it's going to things that physicians prescribe, control, or influence. So point number one is you actually want the physicians to be working with you because they're the people that control most of the expenses. You don't want them to be your enemy. You want them to be your colleague and your partner. Let's talk about how the physicians get paid. So how much money does a highly productive primary care physician make? Well, I'll take a hypothetical, highly productive primary care physician. This physician has 2,000 patients. They work 250 days a year. They only take 2 weeks of vacation. They see patients 7 hours every day. They see 3 patients every hour. They are like a machine working through those patients. They make 5,250 visits per year. How much do they get paid for that? Medicare pays them $70 per visit. A lot of commercial people don't pay them a whole lot more than that. $70 for what's called a level 3, typical 15-minute visit. Now, they do other things. They talk to patients on the phone. They call in prescriptions. They talk to specialists. They don't get paid for that at all. Doctors don't get paid for phone calls. They don't get paid for emails. They don't get paid for any of that. So when you add all that up, sounds pretty good, right? This primary care physician is making $368,000 a year. Well, not quite, because all of the revenue to the primary care practice comes when the doctor bills. So the primary care physician has to pay for all those other expenses out of that. They've got to pay for the medical assistant, the receptionist, the records, the billing clerk, the office manager, all the rent and furniture, all the medical supplies, all their insurance, et cetera. And these are typical average numbers for a primary care practice. They're actually a little bit on the low side. So when you add all that up, what comes out? The physician gets what's left after they pay all those expenses, because they've got to pay all those expenses. They can't run the practice without them. And that's not exactly enough to cover their medical school debt. So what's the doctor do? More visits. Let's see if we can get in 4 visits per hour to be able to actually make the numbers. Well, then you start to get to a number that actually starts to be enough to at least pay off medical school debt, put the kid through college, et cetera. Now, if that physician does what Reed said and said, I want to respond to the patients, I'm going to let them call instead of having to come into the office. Let them email me. I'll tweet back and forth in terms of whether, what they need. So they don't have to come into the office as much. Lots more calls and emails per hour. Guess what? Physician practice goes bankrupt because we pay for office visits. That's all we pay for. We don't pay for phone calls or emails. Now, how much time is actually needed to be able to give good care? Well, this has been studied. This is from one study that said, so how much time do patients on average, some need less, some need more, but on average, a population of patients in practice need? Well, they need time spent on preventive care, some of that call them up to make sure that they're getting what they need, chronic care, acute care, about 2 hours per year per patient on average. So if this physician has 2,000 patients that they're trying to manage, all they need is 16.5 hours a day, every day, to be able to provide that care to the patient. Why not hire a nurse? Could hire a nurse, help do some of that care. Guess what? Nurses don't get paid for, so that comes out of the doctor's salary. Now, if you think I'm making all this up, I put this up as hard to read in the back, but this is a real live family physician who came to a meeting that we had in Cleveland a couple years ago. So I'm a family doc. I've got 1,800 patients. Here's my day. I see 20 to 25 patients, average of 3 problems per appointment. I respond to 25 to 30 calls. I review 30 reports. I write or refill 25 prescriptions, da-da-da-da-da. And then, when the day ends, I'm not done. I end up working in late into the night to be able to catch up on all the stuff I couldn't do during the day because I was seeing all those patients. And as hard as I work, I still can't get to everything my patients need, especially the ones who are complex. So I decided to hire a nurse. We don't do that in family medicine because it doesn't get paid for. But I decided I couldn't afford not to. And it was hard to give up part of my salary, but I thought that it was a good thing to do for the patients. So you have to ask yourself, is it any wonder that we say patients don't get the care that they need? In primary care, we come out with all these studies, 50% of the things patients need they don't get. Is it any wonder that the PCPs end up ordering lots of tests and sending them off to specialists when they have so little time to be able to spend with them? Do you think adding more quality measures on top of that is going to solve the problem alone? And should you ask them for discounts and send them more volume? Where exactly are they going to put the more volume? Wouldn't it be better to actually pay those primary care physicians differently, not necessarily more? A lot of PCPs say, I'm making salary okay, I'm not happy with the way I have to earn it. This is not good patient care. Wouldn't it be better to pay them differently so they actually could answer the patient calls about urgent issues? They could keep open slots on their schedule so that people who really needed it could come in rather than go in the emergency room. Wouldn't it be nice if they could spend more time with the patients who really needed it? And wouldn't it be nice if they could actually enjoy their work more so that we could get more primary care physicians when we need them? How about the specialists? So the PCPs get paid $70 for an office visit. The specialists get paid a lot more than that, right? Double, triple. They get paid exactly the same amount. Specialists get paid exactly the same amount as PCPs. But the specialists have these things, other options. They can do procedures. They can do a stent and get paid $600 if you're a cardiologist. You can do hip surgery if you're an orthopedic surgeon and get paid $1,600 for that. So good for the specialists that they actually have things that they can do that they can earn more money at. The problem is not what they get paid, it's what else goes along with what they do. So when the stent gets done for the doctor getting paid $600, the hospital gets paid $7,000. Whenever the surgeon does the hip surgery for $1,600, the hospital gets paid $12,000. Those are Medicare numbers. Commercial numbers are a lot higher than that in most cases. Okay? Now, Tom asked the question earlier, what about shared decision making? Well, the studies, in fact, have shown that if you spend the time to talk to patients and explain to them what the risks are associated with surgery and what the trade-offs are, that in many cases, not by small amounts, by significant amounts, they will decide that they don't actually want that procedure done. 30% fewer stents, 40% fewer mastectomies, 20% fewer back surgeries. But look at how we pay. We don't pay the specialist to spend time talking to the patient about whether or not they should have the surgery or not. We pay them to do the surgery. That's how we pay.